Thank you all for coming. I know that many of you have other obligations, and coming on a Friday morning on the last day of SAEM is challenging, so we thank you for being here. My name is Rama Salhi. I'm one of the rising PGY4s at the University of Michigan, and along with my colleagues, we'll be talking to you today about teaching diagnostic and cognitive error prevention. I'm going to hand it over to them for just a moment to briefly introduce themselves, if they wouldn't mind. Miguel, do you want to start?
My name is Miguel. I'm one of the residents at the University of Michigan.
Andy King at Ohio State.
Sorabh Khandelwal, Ohio State. Michael University.
Perfect. Thank you all. Okay, so our objectives today will be to compare and contrast System 1 and System 2 thinking. We'll talk also about what that means, and to describe major categories of diagnostic error, and then discuss potential means of mitigating this error and how we may teach these methods on shift to our trainees. So take a second to look at this number. The diagnostic failure rate in the emergency department is 10 to 15%. This is, I think many of us would agree, an unacceptably high failure rate, and the question is sort of what is mitigating these failure rates. So multitasking, certainly we all know that there's a lot going on at shift, that often your concentration is pulled in many different directions, frequent interruptions to take care of more urgent clinical questions or sometimes not, overcrowding contributing to sort of our cognitive burden and having to think about the waiting room and the boarding patients and everyone else who is sort of living in our emergency department in that moment we are also responsible for. And then just the general workplace chaos of being in the emergency department. The lights, the sounds, the large teams, the unpredictable nature of what we do for a living. So all of these things can lead us to many various different kinds of cognitive biases that ultimately end up contributing to that failure rate that we just talked about. Obviously, to address this is an important patient safety issue, and so the two things that sort of lead into how we get to cognitive debiasing include the patient safety movement. So improving patient safety requires dedicated focus on improving diagnostic errors. But to improve diagnostic errors requires that we have an understanding of how doctors think and how they make the decisions they make. So briefly look at this. In those few seconds, did anyone in the room think STEMI? Okay. In a couple seconds looking at this, we see ST segment elevations in the precordial leads and in 3 in AVR. Certainly a quick glance at this, you may think STEMI and anchor on that. Now, what if I told you this is a 34-year-old man who last week had a self-inflicted stab wound to the chest and was doing fine on the psych ward until he developed chest pain? Does that change your diagnostic thinking? Certainly many of us at this point are thinking pericarditis and would potentially take an ultrasound to probe to the chest to look to see really what was going on with his heart. Unfortunately, this gentleman had a lacerated coronary artery and had developed pericardial tamponade when on the psych ward, and when this EKG was presented to the cardiologist, received immediate TPA and unfortunately passed. So you can imagine that that sort of anchoring and cognitive bias ultimately led to a negative outcome for the patient, that had a cognitive debiasing strategy potentially been employed, he may have had a better outcome. So have any of you heard of dual processing theory? Perfect. I know at least that my collaborators have, and none of them raised their hand. So dual processing theory is this concept that we receive a clinical problem, and there are two modes by which we process it. There's the fast pattern recognition mode that we probably operate in most of the time in the emergency department, where we fit patients into illness scripts and heuristics, and then analytical and logical thinking, which is much less of a, what's the saying? Oh my gosh. Off the hip That's not the saying. Is that? Okay. I'm very bad at colloquialisms. And is more of a concerted, purposeful effort to slow ourselves down and think about our patients to ultimately reach a diagnosis. So there is some thinking that our fast pattern recognition may be more prone to bias. The truth is that it's probably a little bit more complicated than that, and that there are various different biases that each of these two different lines of logic are predisposed to. However, we operate mostly in the fast pattern recognition mode, and so that's where we're going to focus our efforts today. So the goal is to recognize that you're prone to bias in this thinking, receive a stimulus, potentially recognizing the complexity of the case, high-risk complaints, recognizing the feelings and emotions of your team that they may be expressing, or environmental factors, recognizing that you may be boarding 50 patients in your waiting room, and on this shift you need to potentially think a little bit differently. And then to appreciate those stimuli and then purposefully employ the debiasing strategies that we're going to talk to you about today. So there are three main biases that our fast cognitive thinking is prone to: premature closure, stereotyping, and incorrect prior probabilities. So premature closure is the overwhelmingly common one that we identify in the emergency department, and we are prone to in the emergency department. We've all heard the saying that when you hear hoofbeats, think horses. But the question becomes, what if your current environment is Africa? Should you be thinking of zebras or giraffes or something else at that point? A really salient example of this is a 2014 Houston ED patient who shows up with flu-like symptoms. All the usual: high fevers, headache, myalgias, runny nose, gets diagnosed with influenza and sent home. Now, there had been a key piece of this patient's history received in triage that he had recently traveled here from Liberia, and many of his close contacts were infected with Ebola. Unfortunately, that information had never been passed on from the triage team to the clinical care team, and so he was ultimately discharged home. Unfortunately, this patient ended up coming down with and then ultimately passing from Ebola. Luckily for the clinical team, none of them had contracted it, but you can see how this gentleman was not potentially operating in the same environment where that saying is appropriate. So what are the cognitive forcing strategies that we employ? And I want to point out that in your handouts there is, on page 3 or 4, I think, a large table that goes through all of these biases and cognitive forcing strategies that you can use. And we also have laminated pocket cards to hand out once we get out into our groups, that if you want to have them on shift, particularly for teaching purposes, are a nice thing to leave in your white coat pocket. So for premature closure, think about creating a differential diagnosis for a patient in each visit. What are plausible alternatives? And certainly, what are the worst case scenarios? And these are things that we teach our medical students and teach our residents, but can sometimes be easily lost, and coming back to them can help us avoid errors in these settings. The next is something that we are all as humans prone to. So stereotyping, first impressions, gut feelings, seeing a patient and having an initial either positive or negative reaction that can influence your care of the patient. I'm going to show you a couple quick pictures, and I'm just going to spend a couple pictures on each, a couple seconds on each slide. We'll sort of talk about them at the end. Can anyone share quickly what they thought of when they saw this picture? I'm sorry? Sure. So you're initially thinking of diagnoses. What illness script does this fit? I know that I have lots of family members and neighbors who are of the same age, and so I may think, oh, this poor child, and potentially that will be the framework in which I treat this patient. Similarly, any initial gut reactions about this gentleman? So the first time I heard this talk, the initial thing that came to my mind was, this guy's having a man flu. This gentleman, the speech bubble doesn't show up here, but certainly when we know our patients sort of ask for narcotics by name, many of us have gut reactions to those patients. And then this gentleman is elderly, many people may initially, in a brutally honest moment, say, maybe we should think about hospice for this patient, or why are we doing this to him, or why is the family putting him through this? So we have gut emotional reactions to all of the patients that we see. When you had these gut emotional reactions, did anyone have an immediate following thought, said, I shouldn't have thought that? And we do on shift often. That's your brain trying to force you into an analytical mode of thinking, and at that point, if we can pull on those triggers, then we can cognizantly employ debiasing strategies. So the next set of potential for error are sort of incorrect prior probabilities, available heuristics, and representative heuristics. So collectively, these sort of summarize the probability of a disease that we walk into a patient room with. So for example, incorrect prior probabilities. We may overestimate the disease prevalence of a certain disease process. An availability heuristic may be your potential fund of knowledge, something you've heard, a case you've missed recently. Representativeness heuristics is also similarly. So the cognitive knowledge base that you're pulling off of, whether or not you've heard a podcast recently, as I mentioned, missed a case, so a particular rare diagnosis is in the forefront of your brain, and all of a sudden, every 20-year-old with chest pain that shows up, you are screening for pericardial tamponade because you missed it a week ago, or heard a podcast about it, or something like that. So the question sort of becomes, when we recognize these, how do we de-bias ourselves and our team? The first is certainly recognition that this occurs, and then asking ourselves, what am I not seeing here, and what else might be true, and forcing ourselves to answer those questions in the correct clinical context. So this is the table that you guys have in your packet, and they'll hand out laminated cards for anyone who's interested. And as I mentioned, the red column is the bias that has been employed and a brief definition of it, and then some debiasing strategies that you can employ on shift and teach your learners how to employ with themselves and maybe the medical students they supervise or other learners or colleagues. So when we think of teaching possibilities, because ultimately what you're here for is not just to talk about errors, but how do we prevent them and how do we teach our team to prevent them? And this sort of becomes repetitively asking your learners to create a brief differential diagnosis. And in particular, this is looking at the most likely diagnosis based on prevalence and pretest probability, the most serious diagnosis, our can't miss diagnoses, and then how do we address these to make sure that we don't miss this. Oftentimes, this can be done with a history and physical exam that is a little bit more deliberate. Maybe you add on a couple extra labs, an image that you may not have potentially ordered initially. This isn't necessarily changing your workup dramatically, but it's about sort of deliberately going through this process. And many of us are taught this, as I mentioned, in medical school. I don't think I'm saying anything groundbreaking to any of you, but this is about pulling it into the forefront of your brain and using it. And then creating learning opportunities for your learners so that this becomes a repetitive pattern that they are using on shift. This is also in your packet. This is an assessment tool that you can use to look at error susceptibility and error prevention strategies that I won't read to you, but just want to call your attention to in the packet. And then certainly there are other teaching venues that we all are part of. M&Ms, including Nearmisses, to study cognition and our susceptibility to biases, and then during didactic sessions, demonstrating using a case with some common cognitive errors, such that we can cue our learners into thinking about this as they're assessing a patient for a medical diagnosis as well. And then a strategy that many of us employ is sort of taking the patient's perspective. I know that a lot of my mentors say, I treat the patient as though it were my mother. And in the moment, I think, if this were my mom or my brother or my child, what would I want done to this patient? So we're going to stop for a few minutes here and take 10 to 15 minutes to break out into small group sessions to discuss a case that we've got. We're going to pass that out to you. Basically, we want you to read this, take a minute or two to read through the case on your own, and then work through the debiasing strategies and try to implement them based on the current case. They might...
But we have people sit in groups before.
And we'll also have our facilitators join you so that we can make sure that to highlight any salient features and draw your attention to important debiasing strategies.
Okay, well, let's get together and we'll talk about, pick a group at random. You guys want to start? Because you all have something in common. You're wearing dark tops.
Oh, yeah.
So one of the things that came up in our circle is one of my recent cases, and it was, I don't know, how do you want me to introduce this? So our debiasing technique that we could use is just talking through this with the patient about the results in front of them. And so I guess I'll relay my personal story again. So a couple weeks ago, or not 1 week ago, it's 2 a.m. A woman fell flat on her face. She's not on any anticoagulants or antiplatelets yet. I CT'd her head because of facial trauma. And it showed a radiologist read as a hedge between artifact, vascular calcification or something, or cannot fully rule out subarachnoid hemorrhage. And I was going to send the patient home. I had a bunch of risk-benefit and alternative discussion with her and her family. They were all from out of town. And in the end, one of the daughter in the room said, well, hold on. So we're all thinking that this could be artifact, but what if it's not? And I said, well, I'll just call the neurosurgeon on call. So I wake up the neurosurgeon. He looks at the CT. He says, no, you got to treat it as real because it's on more than one slice. So either she can go home and come back or repeat the CT at 7 a.m. And the whole family was so happy that I had spoken to the neurosurgeon. They stuck around until 7 a.m. and we repeated the CT. It was stable and she went home. But the way to debias against this whole artifact versus other anatomical abnormality was for me to really speak through the radiologist's impression right in front of them from the paper to them to get their questions and to debias myself a little bit. You know, maybe this isn't just artifact. So the corollary with the case of this ectopic was that if the resident had gone back in and spoken to the patient about all of her abnormalities, particularly this left lower quadrant mass, would the resident have tripped in his mind something to think, you know, this doesn't really make sense. Why, you know, is this really what I want to do and just downplay this mass and just move on with non-viable IUP? So that was what came up in our group a little bit.
So it sounds like what you did was sort of forced yourself to explicitly move into an analytical thinking process such that it sort of tripped you into doing.
What were the biases that you guys thought were in play here?
We decided it didn't matter. It was an interaction.
Right, okay.
The names didn't matter.
Which is not so unreasonable. I mean, I think it's nice to know, to have the names, because it kind of starts getting your mind into the thinking about how you think. And that's when you can start making changes in how you think and think about, see, when I see somebody who says, you know, this person's got constipation, that's on my list of most dangerous diagnoses in the emergency department. It goes along with gastroenteritis, a cold, a normal EKG, a normal chest x-ray. I think these are the most difficult things to diagnose. And that's the mindset I'm going in because I know about all of these cognitive biases. Why don't you guys, what do you want to share what you thought? Who's the share?
My name is Ryan Heaney. So what we noticed about the case is that there seemed to be a pretty bad case of triage queuing. I think we all see that a lot in our emergency departments. One thing that was mentioned that is being done at the University of Michigan, mentioned by Carrie, was that they put the word pregnant on every single patient that is pregnant who comes in for any complaint. And I think that's a really good idea because where I work, we have a fast track, and patients can be seen independently if they're a level 3 low, like probably this patient was, by a PA, and they don't have to staff it unless they decide it's a pregnancy-related complaint. And I've seen cases come through and that were abdominal pain, and they thought that was not pregnancy-related complaint because they anchored on pellet stool and things like, and they haven't had a bowel movement in a day and things like that weren't really relevant. So I thought that was interesting. And another thing that we noticed was that this resident in our case here had confirmation bias. They were kind of discarding information that did not fit what they had already thought was going on with the patient. And then they were just really anchoring on some features of the case that wasn't the most pertinent thing. One of the things that we talked about doing is, say, like turn it into a quiz or turn it into a board review question. And what are you supposed to do? If the resident suggests to you, I have a 85-year-old patient with flank pain right into their back, I think it's a kidney stone, I want to get a UA and discharge them. If that was a board question, they would never get that wrong because they've answered that board question a million times. But sometimes, at least my residents will suggest that, even though they know you obviously need to do much more thorough workup, CAT scan, probably CTA. I think the other thing that on this case was important is just the vital signs. Like, you always need to address your vital signs. This person was getting worse. And so that's another thing that can be a major cue to step out of your type 1 thinking and go into the more analytical type 2 thinking and ask yourself, well, why? What else is going on here? What could I be missing?
One other cognitive error that we discussed, it isn't on the table. So in the last paragraph, it mentioned this cannot be a heterotopic pregnancy because they're rare. So some of the literature calls this a zebra retreat. So the fact that this is so incredibly rare, despite all of the information pointing to the contrary, that this cannot be a heterotopic pregnancy.
Do you guys want to add anything?
No, but we probably had a little bit of premature closure on this case as well.
Yeah, and I find that most of these biases that are listed on the card, and for those of you that are interested in the bibliography, we list Pat Crosscarry's original article from the late 90s where he lists 40 or 50 different categories or different examples of cognitive biases. And I don't think it's important that you know the individual biases, but that you understand that all these things can happen. And every once in a while I'll go back and look at the list and just say, oh, which ones have I done recently and which ones have I seen recently? And it sort of gives you an idea of what the landscape is for the different, many, many ways that we can all prematurely close a case. And almost all of these are examples of premature closure. Your group, Rama?
Yeah, did you guys have anything that we wanted to? Yeah.
So just similar thing to what you guys were saying with the diagnosis. With the diagnosis momentum, there are multiple different parties that were kind of contributing to this constipation. The patient, the radiologist they're like, oh, this left diagnostical mass, but even they kind of write it off. So those are all kind of weighing against this resident getting the diagnosis with premature closure. One thing looking through this case as well is there are some use of kind of debiasing techniques written into the case. So this first line of the second paragraph mentions how the attending sees the patient without looking at the triage note, kind of as an attempt to prevent some triage bias. We talked a little bit more about kind of some debiasing strategies that we could use.
What were some of those ideas that you had?
Well, so looking at kind of the structured reflection piece and having a diagnostic timeout. So with looking at it from the resident standpoint, in residency we have, I guess every case we kind of get a diagnostic timeout when we staff it with the attending. Moving on in the future, when you're not necessarily staffing every patient you see primarily, incorporating that into your workflow would be something worthwhile.
Rama, you wanted to finish up just a couple more slides?
Yeah, absolutely.
Anyone have any more
Any
comments
other-
about the case?
Just out of curiosity, did anyone sort of employ, I really like the technique of, if this were me, if this were my sister, if this were my daughter, what would I want done? And if it were my sister, there was no way I was going to let her get out of that ER without seeing a gynecologist. So that's an interesting strategy, and something that I learned more in the debriefing world around more social constructs of biases is a really powerful tool, and something that I use with my more junior med students is repeating back to them what they've said. So they fully staff and they go through everything, they get lost in the details, and I repeat back to them, okay, this is a 30-year-old pregnant woman who came in with left-sided belly pain, has a mass and decreasing vital signs. An enema is probably not the right thing, right?
Yep.
And so sort of pulling those salient features out to teach them how you're thinking about it as well, to sort of restructure.
And as part of the debiasing process, I would ask, what are the pros and cons for the diagnosis that you've come up with to the resident who's now said that this person is constipated, and they would tell me, well, she's got pain and she hasn't moved her bowels, and say, well, anything on physical exam? Yeah, she's tender in the left lower quadrant. Okay, those things all go together with constipation. Is there anything else that you ought to be looking for? You guys aren't allowed to say. Got it. Anybody? Anything else that you want the resident, any other fact or piece of information that you'd want the resident to find to include that diagnosis? I know we don't like to do rectal exams, but how about a rectal exam? This might be one of the places where that is appropriate to do.
Yeah, absolutely. So we are running up on time, but the one thing that we just wanted to briefly mention as a sort of up-and-coming thought process is sort of the role of distributed cognition in error prevention. So what we've talked about is a lot of the language and debiasing strategies that we use either for ourselves or in a one-on-one setting with a learner. But the truth, and so these traditional cognitive theories sort of suggest that we as users in a specific place and time are the area of impact for these debiasing strategies. Distributed cognition sort of takes it one step further and says, I am influenced by what I thought an hour ago or the case I saw a week ago, and sort of really looking at these temporal trends, and that my cognition includes other external representations and other people, as we've all sort of talked about. And really, the distinction here is subtle, but it's sort of moving from saying I am debiasing myself or my learner to I am debiasing my team. And I just sort of want to take a moment to talk about, this is probably a more appropriate model for when we talk about cognitive theory. If you imagine that you're sort of the larger head in the middle, you are over time and space interacting with other people, the patients, the nurses, consultants, patients' families. You're getting data in various pieces and readjusting and restructuring your differential diagnosis. You have interaction with your pocket brain, so you look something up on UpToDate and say, oh yeah, like maybe this is parotitis and you need to do something else, that kind of thing. And so this is really just to hand this tool back to you and say, while we've taught it to you in sort of a one-on-one setting or a self setting, you could probably start to employ these strategies to help debias your team as well. Any questions? We thank you guys so much for being here and participating in the conversation. It was a really good discussion. We hope that you've learned something to take back to your learners and ways to employ this on shift.